Well, thank you, James, for that very kind introduction. It's, I think, I'm not related at all, as my daughter, who was graduating college at the time, had to put on her resume in any hopes of getting a job. But it's a special honor to be here for this big centenary celebration. A real honor for an American lad to come over and have a chance to participate. I too, like Sam, got a call actually from Jonathan Earnshaw, and he wanted to know if I could give a little chat to a little group, and it sounded like really not much of a project, and it was going to be on surgical research, and I said, oh, that's fine, fine, fine. And then I asked my advisor, my wife, I said, what do you think about that? And she was a little skeptical and said, kind of a broad subject, don't you think? And it's kind of a broad subject. So I'm going to arbitrarily cut it down into size, make a few general comments about it. And I want to really break my talk into three parts. I want to talk about sort of the fundamental heritage that made surgery what it is today, and that really falls into the 19th century. I want to talk about when surgeons were kings roaming the earth, 20th century surgical research, and just a tiny segue into Aradarzi's talk of 21st century research, but I'll barely touch on that at all. One reason why surgical research is a big topic is because it's very hard to define exactly what it encompasses. So we all agree that a surgeon doing research is doing surgical research. There are non-surgeons who do surgical research. If you think about Pavlov making gastrostomies to do his physiology experiments, that could be surgical research. Non-surgical research by surgeons, think of Alexander Fleming in penicillin. Think about Frederick Banting in insulin, surgeons that have made important medical advances. So what is surgical research? I'm not going to answer that. Broadly based. The other piece is that surgical research has not always had the greatest reputation. There are cynics, shockingly, out there. I'll let you fill in the blanks. But there are those that think that this applies as well. So I picked this Paul Gauguin painting, famous painting. Where did we come from? This is the title. Where did we come from? Who are we? And where are we going? So let me start with where did we come from? In the early Common Era, medicine was informed by the thoughts of Galen. His thoughts were informed by Hippocrates. This was the time of the four humors and the four associated temperaments that are seen in this great etching on the right. The first surgeon, or an early surgeon, that didn't exactly research, but wrote stuff down was Ambroise Paré, a barber surgeon, and he had some very useful advice for future surgeons, like don't pour boiling oil into open wounds, and it's better to tie off an artery than stick a red-hot poker into it. So they are words for all of us to live by. The rise of surgery is a three-legged stool. The legs are anatomy, asepsis or antisepsis, and anesthesia, the three A's. And they're really all innovations of the 19th century, except anatomy. So anatomy, father of modern anatomy, Andreas Vesalius, from Padua, also a surgeon, by the way, known as an anatomist. But what he did was fundamentally changed how the world looked at medicine, because he really shifted us away from Galenistic thinking and away from the humors and into, Galen had actually worked dissecting Barbary monkeys and tried to infer what humans were like. Vesalius, one way or another, found bodies and was able to deliver us the raw clay that we could work with as surgeons and that knowledge base. In surgery, anatomy, of course, is absolutely essential to surgery and to the surgeon. And here's William Hunter, John Hunter's brother, who says it very succinctly, that anatomy is the basis of surgery, informs the head, guides the hand, and familiarizes the heart to a kind of necessary inhumanity. Well, what's that, and why is that? No anesthesia. So surgeons did bold operations, they did fast operations, but the patient truly suffered. And the reports from patients when they describe what it was like to have surgery are really astounding. So speed was highly prized in the 19th century. Here's Florence Nightingale saying that all other things being equal, the operator's success is in direct ratio to his quickness. So we look for quick surgeons. Here's Robert Liston, known as the fastest knife in the West End. He's actually another Scotsman. This talk is loaded with Scotsmen. He's from Royal Infirmary in Edinburgh, I believe. Time me, gentlemen, time me. 6'2", operated in his Wellington boots, and often to keep things moving along, he would take the bloody knife and hold it in his teeth while his hands were occupied. And he's famous for a few different cases: a 4-minute removal of a 20-kilogram tumor of the scrotum, a 2.5-minute leg amputation that unfortunately also took off the patient's testicles, and most famous of all, 2.5-minute leg amputation that he did not take off the testicles, but he cut off his assistant's fingers. But it was quick. It was very speedy. So during this time, the idea was, well, maybe there ought to be a way to do this a little bit more leisurely and with a little bit less pain for the patient. And here is Henry Hill Hickman, also a surgeon, and this is, the road to modern surgery is littered with bad ideas. He experimented with using carbon dioxide as an anesthetic, and he would take dogs and basically narcotize them until they were almost dead, and once they were almost dead, they didn't mind having a leg cut off. And this led to a famous letter by anti-quack to the Lancet, calling this surgical humbug. And that's actually the seeds of, as we know, anesthesia came into play in the 1840s and 50s, originally by a dentist. Here is a reenactment of the first anesthesia at the Ether Dome at Mass General. Andy Warshaw can probably attest to this a little bit, but John Collins Warren actually used ether for an operation and said, "Gentlemen, this is no humbug. This is in response probably to anti-quack." But it opened up a new world for surgeons because now you didn't have to rush so much. And in fact, Robert Liston himself was the first to use ether in Europe, and he thought this was great. So he had a flexible mind for doing things. So the last leg of the triad is antisepsis and asepsis. And there's a great quote from Frederick Treves that about surgery before the days of antisepsis. He said an executioner might as well manicure his nails before chopping a head off, was how surgeons viewed cleaning up before operations. So here's the road to germ theory. None of the individuals on the left are surgeons. Semmelweis, obstetrician. This in the picture is William Halsted doing an operation. You can actually see the nurse on the right of the image wearing rubber gloves that Halsted devised and had custom made for him by B.F. Goodrich, the tire company. And of course, Joseph Lister, another Scotsman, who really brought asepsis and antisepsis to the fore with his carbolic acid. So, This is a remarkable book. For those of you that have not read it, it was first published probably 60 or 70 years ago, The Structure of Scientific Revolutions. And its thesis is that normal science proceeds, and this is in the current model accepted by all of the practitioners, until it gets stuck. And then somebody has an insight, a fundamental change occurs in the field. It's really literally revolutionary in things, and the whole frame of focus shifts. So you think of Copernicus changing from a heliocentric, changing to a heliocentric world from an Earth-centric world, universe. Lavoisier, oxygen theory of combustion instead of phlogiston, Einstein, and Newton. And what I want to propose is that really at least two of these radical changes in the mid-19th century were scientific revolutions. So anesthesia, maybe not so much. It opened the doors for a tremendous number of advances because you could operate painlessly and take time, understand what you're doing. But anatomy and antisepsis, really, if you talk about the impact of surgical research, really changed how we thought about people, how we thought about medicine, how we thought about the world. None of us, of the physicians and surgeons here, really think much about black bile causing disease, except James and his friends. Our whole framework, conceptual framework, changed with these advances in the 19th century. Well, who are we? And this, I want to turn to the 20th century, and there are a lot of examples to pick, but I wanted to pick the example of cardiac surgery developed in the second half of the 20th century, just to give a thought for how the surgical process, surgical research process, works as a purely, almost purely surgical process. So I talked about how Copernicus changed the world, put the sun at the center of the solar system. Here we are, it's now the 20th century. Here's a Copernican map, and there's a little color thing in the middle. So what is that? Surgeons. Because in this era of surgical research, they are the center of the universe, and a lot of the universe rotated around them. And we just saw that in the slide that Sam showed from the New England Journal of Medicine, that same period when there's this tremendous spike in surgical publication. So the road to cardiac surgery, I can't do it all. I'll mention that the first cardiac catheterization was by Werner Forstmann, who was actually a surgical intern when he had this idea that you could actually put a catheter up your arm and into your heart, and convinced a nurse he was going to do it to her, and then secretly did it to himself and got her to help take this x-ray of him. Open heart surgery became possible with the pump oxygenator. And the name most associated with this was John Gibbon of Philadelphia, but there are other parallel developments. One point I'll make about this is that the Gibbon oxygenator was actually developed in association with IBM. And that association came strictly through chance. Gibbon's Army buddy was the son of Thomas Watson, the president of IBM, and they got together. But it was the surgeon that approached industry for help. And I think it's actually, maybe Ara Darcy wants to talk about this later, the relationship, I think, has shifted a little bit now. And we're seeing a lot more of industry approaching surgeons. And actually, General Motors also helped the surgeon develop a pump. Anyway, so John Gibbon develops the pump. New opportunity. He fixes an atrial septal defect 60 years ago. Fixes an atrial septal defect successfully on the pump. It's a fantastic leap forward. Then he does 4 more patients, and they all die disastrous deaths, and he stops doing open heart surgery. A dead end, it seemed. When he gave up open heart surgery, he actually gave the blueprints to his heart-lung machine to John Kirkland at the Mayo Clinic. And this is really the forerunner of modern open heart surgery, this pump that you see here. But on a parallel track, other surgeons were thinking. So here's William Mustard from Sick Children's in Toronto, and he had the idea, what's a perfect oxygenator? A lung. So he got a bunch of rhesus monkeys at $40 each. He took their lungs out, attached them to a pump, and he did open heart surgery pumping patients' blood through rhesus monkey lungs. Did not work out that well. John Lewis, this is University of Minnesota, tries total body hypothermia in inflow occlusion. He goes to the Sears Roebuck to get a horse watering tank, fills it with ice, cools the kid, stops the heart, sews the hole, everything comes out great. Watching this is Walt Lillehei. Walt thinks, this is stupid. There's got to be a better way to do this than going to Sears Roebuck. So he comes up with what was really thought to be one of the stupidest ideas in the history of surgery, cross-circulation. And this idea actually came to him, not to him, but to Morley Cohen. You see here, Morley Cohen was in his lab. Mrs. Cohen was pregnant at the time, and Morley got to thinking that her placenta was a great pump oxygenator. So Dr. Lillehei came up with the idea of cross-circulation, which you see in the lower left panel, where actually the patient's mother serves as the heart-lung machine for the child. And you can see in the picture on the bottom right, you actually see down here, here's the patient being operated on, here's the parent being the pump oxygenator. Remarkable. And just to cut the story ahead a little bit more, looking over Dr. Lillehei's shoulder there is Norman Shumway. So Dr. Lillehei does his cases. He goes to the American Surgical. But this was, sort of a Promethean moment after he steals the fire and then gets his liver pecked on. But in fact, this was not a new invention for Dr. Lillehei, because it turns out Robert Liston actually had done an operation with 300% mortality, rule Britannia. But if you think about this, this was surgical research in its heyday. Here are these guys, and you have to have a tremendous degree of admiration for the sheer courage that these guys had to take a tough problem. It was really a quite purely surgical approach. And the perseverance that it took, the creativity, if you think about monkey lungs and cross-circulation, machine oxygenators, and the perseverance to go through the high mortality of those early days, the vision, the ability to collaborate, Dr. Gibbon giving his pump to Dr. Kirkland, and the sheer luck involved with how things worked out. It's really, I think, in many ways, a high watermark of surgical research. So where are we going? I'm just going to say a very few words about this. There are strictly surgical technical advances moving forward now, but I think the pace of inventing new operations, from my vantage point, is probably slowed since the earlier days when many of the discoveries have been made. But so here we have, working on minimally invasive surgery. Right now, part of this is an industry-driven process. We talk about robotic surgery. We're not actually there. When we have robotic surgery, we will have Rosie Jetson going into somebody's abdomen and bringing back the colon. Right now, it's the surgeon still doing it, but we're making progress. But it was an earlier time when surgery could stand alone and solve all the world's problems. So here's William Halsted describing radical mastectomy as the solution to the problem of recurrent breast cancer. And the answer, cut bigger, cut wider, cut better, but surgical. Turns out progress is not totally linear. We know that from everything. So you start in the 19th century, before Halsted, with non-radical resection. Halsted shows up in the 1890s, advocates radical mastectomy. Future surgeons advocate super radical mastectomy. Then in the 1980s, a couple of surgeons say, wow, that's cutting a lot of stuff. This is probably a systemic disease. So all of a sudden, we're doing breast-conserving surgery and taking out the axillary nodes. Then we come up with sentinel lymph node biopsy. And now we're doing breast-conserving surgery without taking out the axillary nodes. And what's made that possible is that advances, not surgical advances, but advances in the other field. We give radiation therapy, we give chemotherapy, hormonal therapy, and targeted monoclonal antibody therapy. So it's no longer strictly a surgical problem. And we see this expansion of the surgical realm in a sense. We see Judah Folkman. Here's a young picture, very young Judah Folkman. Beginning his work on angiogenesis, you can see that very elegant rabbit corneal model with a tumor implant on the eye and blood vessels coming to feed it. He's a surgeon, chief of surgery at Boston Children's, but this research is not surgical, strictly speaking. Stephen Rosenberg at the NIH adopted immunotherapy, activated T cells to kill advanced cancers. Very successful, very innovative, but not done with a scalpel. So as I look at surgery now in the 21st century, I think it's in comparison to 100 years ago or 50 years ago, surgical research is not strictly a surgical endeavor. It involves other disciplines. It relates more closely to basic science than just the surgeon standing alone. But we all have the same impulse. Thank you very much.